Hello and welcome to Optimizing Cardiac Health to live young for a lifetime. My name is Adair Anderson. I'm the product marketing educator here at Vibrant and want to go over some housekeeping items before we get started. All attendees are in listen only mode. If you have any questions during the presentation, please submit them as a comment. There will be time at the end for Q&A, and we will go through all the comments at that time to make sure we address all your questions. And now I'm pleased to introduce you to our speaker, Dr. Jeffrey Gladden. He's a cardiologist turned longevity expert with an impressive biological age, I might add. Take it away, Dr. Gladden.
Oh, thank you. Appreciate it. So I wanted to speak with you today, give you a little bit of sense of context in terms of where I'm coming from. But in my journey, and I'll walk that through for you in just a minute, but in my journey, one of the things that I've come across that's really, really critical in this whole longevity conversation is how we frame up longevity itself. And for me, people talk about longevity all the time. I just got done shooting a documentary yesterday with some people on Biohack Yourself. And it was interesting to talk with them. They've interviewed many experts in the longevity biohacking arena. And yet everybody seems to be looking at longevity as living for a long time. And I think that when we think about what we really value about ourselves, it's really being youthful in terms of our physical abilities, and also very wise in terms of our mental and psychospiritual abilities. So for me, if you're going to think about longevity, the question becomes, what's the target? What are you actually going for? And so the way that I kind of summarize that, if you will, is to say, I'm going for a 30-year-old body and a 300-year-old mind. And I think if you think about that for a minute, you'll start to see there's a real impact that has on the way you think about longevity, if that's really the target. So in my own case, I have a birthday coming up tomorrow, February 28th. And I will have completed 70 laps around the sun, which is an interesting thing. I'm taking the day off to actually contemplate that. I've never done it before. And yet, one of the things that I do in my own journey with longevity is to wake up 27 every day. So I wake up 27 every day. I'll be 27 for the next decade. And the next decade, I'll be 28, the next one, 29. And when I'm 100, I'll be 30. And I have to tell you that waking up 27 is such a dramatically powerful mental exercise, right? So I would encourage each of you, we're going to talk about cardiovascular disease. I'm going to share some insights with you that I learned actually after I left traditional cardiology that I think you'll find interesting. But as you think about it, what I really want you thinking about is how old do you want to be for the rest of your life? In my case, I want to be 30 when I'm 100. I want to be 27 today. I was out for a run the other day and I was contemplating this birthday coming up. It was maybe about 10 days ago. And I was thinking, wow, 70 laps around the sun, I mean, that's a number right there, right? And so I was running along and I'm feeling that chronological age, if you will. And then I thought, you know what, to heck with that. I'm 27. And I immediately started running faster. I immediately started running easier. And I had like this great run. And the point is that, what we think is true becomes true. In the quantum field, we end up creating our own reality. And so you can create your reality and you can create the reality, help your clients and patients create their reality, if you will, by maybe adjusting your thinking around longevity into, how do I have a 30-year-old body and a 300-year-old mind? And I wrote a book about this. I'll show you at the end. 100 is the new 30. And I go into lots of this in great detail. But today what we're going to do is focus on the cardiovascular piece. It is February after all. And I'm going to talk you through a couple of things. So the first is a quote by Thomas Sydenham, a person, at the time it was a man, we'll sort of change the gender around here, but a person is as old as their arteries, right? So this is still true to some extent. I will just say this about the age of an individual, and that is that in our world, we're now starting to hear more about biological age and ages, right? We have a glycan age, we have a DNA methylation age, we have a telomeric age, et cetera. And I think one of the misnomers in the longevity space is that people get a biological age done. It even could be an algorithm based on some routine lab tests. And they say, well, my my biological age is 5, 6, 7, 10 years younger than my chronological age. Therefore, I'm good, right? And I have to tell you that in our world, we're measuring 60 different biological ages for people. We are all a mosaic of biological ages, and you need to think about that and understand that. I just got off the phone earlier today with a woman who has stage 4 breast cancer, right? And so she came back with a glycan age that was 10 to 15 years younger than her true chronological age. She had a DNA methylation rate of aging that was less than 1. It was 0.97. She had a DNA methylation age that was also younger than her chronological age. And yet she is going downhill with a feeding tube with breast cancer, right? So the point is that you really have to take these biological ages with a grain of salt. And we're really only as young as our oldest age. And so think about that as you think about your own patients and your own clients. So this is my background. I'm an interventional cardiologist by training. I came to Dallas, Texas in 1988. I practiced this for 25 years. I ended up building my own heart group. This is a heart attack. This is an LAD that's totally occluded. We would go in and open it up, put a stent in, reestablish blood flow, do some things to mitigate reflow oxidative damage that would happen to the downstream myocardium. And, I loved this work. I thought it was terrific. I thought it was wonderful. And yet, there were better things to do. So this was a flagship office that we had. We had 10 offices, 12 doctors. We flew around in little A36 Bonanza to outlying areas around Dallas, Texas. I started cath labs, STEMI programs, CHF programs, AFib, and I had the opportunity to co-found this heart hospital in Plano, Texas with one other cardiology colleague of mine and the people at Baylor. And that was about 20 years ago, right? So this has become a great heart hospital, but it's the place that nobody wants to go. And my only connection with it in the last 10 years or so has really been to give lectures to the cardiac rehab people on how to never need this place again, right? It's a wonderful place if you need it, but nobody wants to go there. So I want to talk to you today a little bit about understanding the cardiovascular system, how I look at it and think about it both from the standpoint of anatomy, physiology, heart, blood vessels, and the nervous system. And so typical cardiac evaluation, what is the history? You still can't get away from the history, even with all of our technology, right? So this is very critical that you talk and ask and listen. And then physical exam becomes important. Family history becomes important. But I can tell you that some of that's been superseded by genetic testing that we do, particularly when it comes to family history. So one of the tests that we like is the CardiaX. This happens to be a Vibrant test. Been using this probably for the last, I think actually ever since it came out. We've been using a company out of Australia called FitGenes that has a nice test that also looks at cardiovascular markers as well as oxidative stress. Been using this for probably over a decade. And we work with a company out of Austin, DNA, Intellex DNA, which also has developed some very nice panels with regards to many factors, everything from macular degeneration to detox pathways to cardiovascular risk, diabetes risk, et cetera, et cetera. And we like their reporting very, very well. I don't think there's anybody on the planet that reports on genetic SNPs better than Intellex DNA. Very, very comprehensive in terms of their understanding of how the SNP works, what it does, and the interventions that you can take to modulate the genetic expression. And then the company Invita is another one that we've started using, which basically here what we're looking for is kind of oddball things. It could be risk of cancer, but it can also be, they have a panel that looks at cardiovascular risk, like does somebody really have a risk for hypertrophic cardiomyopathy? Do they have an outstanding risk for aortic aneurysm or a congenital arrhythmia or a bypass pathway or something like that. So we look at this as kind of a screening tool. But in a combination of doing these, we get a pretty good feel for where somebody's at. And I'm going to walk you through this in a little bit more detail. So when it comes to anatomic testing, I'll come back to the genetics. We'll walk through the CardiaX in a minute. Echocardiogram is important. We do carotid intimal medial thickness testing on everyone. The echoes we don't do for everyone. CT angiogram, you're probably familiar with clearly, which is an AI assisted CT angiogram. Essentially, the software here, I was around doing my cardiology work as this was being developed. And back in the 90s, when intracoronary ultrasound first became available, I became an early adopter of that. And so when I could look inside the artery and see it from the inside out, all of a sudden I could do more work, get better results, make sure the artery was truly open, the stent fully covered the plaque, that it was fully deployed, fully expanded. And it led to us being able to start cath labs in hospitals that had no surgical backup. And we had an incredibly strong safety record because we could actually see what we were doing, not only from the angiogram, but also from the inside out with this ultrasound image. So the Clearly CTA people took the CTA and said, can we mimic what they were able to do with intravascular intracoronary ultrasound? And that's really what that AI is really trying to do. It's trying to look at the cues and the data sets to intimate what would the ultrasound be telling us. And it's actually gotten fairly good. It does still have some limitations. Calcium, of course, blocks X-ray coming into the artery. And so it can obscure what's happening to some degree. A stent itself can obscure what's happening to some degree. That being said, we find it to be a useful tool. We don't do it routinely on every person that we see, but it's one of the first things that we'll go to if we need further anatomic definition of what's going on. And then cardiac catheterization is something I was trained in. Of course, did many cardiac catheterizations, thousands. Intracoronary ultrasound, I like this a lot. And then cardiac MRI for structural heart disease, et cetera, can be very helpful. So we do this. And then there are coronary calcium scores as well. And to do a coronary calcium score, you should understand what it's telling you and what it's not, right? So a coronary calcium score is essentially showing you plaque that's calcified in the artery. And it's really just the tip of the iceberg, right? Like in an iceberg, what percentage of it is above the water? It's a small percent. The same is true with calcium in an artery. Many times, if you see calcium, you know there's soft plaque. But if you don't see calcium, it's kind of like a biological age. You can't pat yourself on the back and say, oh, I'm great because I have no calcium. Because many times we would see people, they would still have symptoms. We take them to the cath lab, we do intracoronary ultrasound, and they're full of soft plaque, like full of soft plaque. So again, take a coronary calcium score with a grain of salt. It is a risk factor. The more calcium you have, the higher your risk, but understand what it's telling you and what it's not able to tell you. It's not telling you about soft plaque, and soft plaque is more vulnerable plaque. And we're trying to get at that a little bit better with Clearly CTA. So hopefully that gives you a little perspective on that. So then what about stress testing? What about physiological testing, beyond an ECG, right? So we know an electrocardiogram is really pretty much, I won't say it's useless, but it's pretty useless when it comes to actually diagnosing whether somebody has coronary artery disease. If they've had a prior infarct, if they have a scar tissue in the inferior wall, the anterior wall, lateral wall, posterior wall, you can pick those things up on an EEG or an EKG rather, but you can't really diagnose a lot and you'll miss a ton. Regular treadmill stress testing, in women, it's a 50-50 coin flip, right? You do a stress test, you try to get them to 85% of their predicted maximal heart rate. You're looking for ST segment changes. Many things can cause ST segment changes. And then trying to interpret those and decide whether or not somebody has ischemia or not becomes very, very tricky. So I've given up, quite honestly, on doing stress testing. And I'll let you know that I was board certified in internal medicine. I was board certified in cardiology. I was board certified in interventional cardiology and nuclear cardiology. And so we did a lot of nuclear stress tests as well. And nuclear medicine, when I was training, it was unclear medicine. It never really got a whole lot clearer. But we did thallium scans and we did, PET tests, cardiac PET stress tests as well, right? So had a lot of experience with that. But the thing that I came to really love the most is the cardiopulmonary exercise test. And I'm going to go through this with you in detail. We're going to go through some genetics. We're going to go through some of these tests. This is just kind of the outline for you. But a cardiopulmonary exercise test has the ability to show you anatomy and physiology in an exquisite way that blows away every other stress test out there. Then measuring blood pressure, right? So this is simple, right? We measure it sitting, standing, left arm, right arm. You know that blood pressure gets higher the further you move away from the heart, right? So the blood pressure you're going to measure in your ankle is going to be higher than what you measure in your biceps. And then we've started using cardiac action which is actually a blood pressure cuff that goes around the bicep, and it's measured at the brachial artery. And it has the ability to take the blood pressure twice, both sitting and standing. And from that, there's a computer that will tell us with great accuracy, actually, what the central aortic blood pressure is. And that becomes important because there are medications out there that will lower the blood pressure in your arm, but will raise your central aortic pressure, right? And the reason we even measure blood pressure is because we're trying to understand what is the central aortic pressure, because that's the pressure that drives heart disease, drives strokes, drives kidney failure, etc. So with cardiac action, we're actually able to get a look at what is the central aortic blood pressure. And it also gives us an idea of the stiffness of the artery. So they can actually measure with a computer the reflected wave of the pressure waveform as it comes off the brachial artery. When it comes out of the aorta into the brachial artery, it bounces off that wall and comes back. And the rate at which it basically oscillates back, you can get an idea of the stiffness of the arteries. So with a CIMT, of course, you're looking at carotid intimal medial thickness, and you're looking to see whether or not there's plaque. But this is a way to actually get at arterial stiffness, which we like a lot. So this is a test that we use on everybody. Max Pulse is another test that we like a lot. This is basically a sensor that goes on your finger, and I'll talk to you about this too, but it measures both electrical impulse and a pulse wave analysis. And we'll talk about that in just a few minutes too. And then measuring heart rate variability. Heart rate variability, we do measure that with Max Pulse. We also measure it with something called Brain Tap. And heart rate variability is really the balance in the sympathetic versus the parasympathetic nervous system. It's really autonomic nervous system balance. And as you know, with white coat syndrome, people come in, they're sympathetically driven, their blood pressure goes up, their heart rate goes up, right? So measuring heart rate variability, which is the beat-to-beat variation in the heart rate, right? It's not my heart rate went to 70 when I walked down the hall and it was 50 when I was sitting. That's not heart rate variability. That's heart rate change. Heart rate variability is the beat-to-beat variation in heart rate, if you will, with respiration. And so when you inhale, HRV goes up. When you exhale, it goes down. And the idea here is that it's a direct measure of the sympathetic and parasympathetic nervous system balance. So we get a look at that with Max Pulse also. And there are ways to measure that at home, right? So people that wear Whoops and Oura rings and Garmin watches and biostraps and things like that, they can get a reference of their heart rate variability. And this can correlate to somebody's readiness score to take on additional physiologic strain. So what we've learned from wearing Whoops for a long time is that when you are physically stressed, let's say I go for a big mountain bike ride on Saturday, Sunday morning, I may wake up and my heart rate variability very well may be lower, meaning that my body is more stressed. I have had more sympathetic tone in my body. And so I'm not going to do a big mountain bike ride on Sunday. I'm going to exercise. In fact, I exercise 7 days a week, but I use heart rate variability to tell me how intense I should work on a given day. And I think if you instruct your clients about this, I think it's very important. So one of the things I've learned in longevity is that it's really important to have people exercise every day. Because if people say, well, I'm going to exercise 5 days a week, I'm going to exercise 3 days a week. The problem with this is you have to wake up in the morning and decide, is today the day, right? And once you actually introduce a decision into the equation, the failure rate is 100%. It's actually 100%. So if you want your people to exercise, and who doesn't? Exercise is God's gift to longevity, among other things, is one of them. Then what I tell my clients is I want you doing something every single day. And what we're going to do is we're going to adjust what you do on the day based on what your heart rate variability is, right? When your body is more stressed, we'll do something else. We'll do balance training. We'll go do something lower level on a bicycle or something like that. When your heart rate variability is higher, I want you pushing harder. I want you riding your mountain bike for an hour. I want you going for a run. I want you doing HIIT training, high intensity interval training. And so that's how we do it. But you take the decision out. So really important, never give people that, I want you to exercise 3 days a week. I think you really do them a disservice when you do that. So the CardiaX report, we've liked this report. I liked this from the first moment I saw it. And it's basically looking at SNPs. It looks at hypertension, dyslipidemia and metabolic disease, some advanced predictive markers of cardiovascular events, and a little bit on detox and methylations. This was developed by Mark Houston at A4M. Many of you are probably familiar with him. The hypertension SNPs, the CYP1A2, everybody's familiar with this from caffeine metabolism rates. And you're probably also aware that there's really only two types of caffeine metabolizers, fast metabolizers and slow. So if you're homozygous for slow metabolism of caffeine, you're slow. If you're heterozygous, you're slow. If you're homozygous for fast, then you're a fast caffeine metabolizer, right? And so you can get away with drinking more caffeine. But caffeine in general, and particularly if you're heterozygous or homozygous for slow caffeine metabolism, you have an increased risk of heart attack, high blood pressure, aortic stiffness, right? These are things we're now measuring, as I showed you, with the cardiac action. Aortic insufficiency, tachycardia, arrhythmias, vascular inflammation, which is a real driver of arterial stiffening, right, and thickness. And I'll talk to you a little bit about senescent cells in the arteries. It's when senescent cells form in the arteries. They're bigger than normal cells. They take up more space. They're more inflammatory. In addition to plaque, you get these thicker, bigger cells. The artery gets stiffer, right? So you can think about stiffness in the artery that we're measuring with a cardiac action as being an indication of how senescent are the arteries. How many senescent cells? What is a senescent cell burden in the arteries, right? So it becomes kind of a surrogate marker for that. Then you've got genes related to hypertension. This one we like a lot. It has to do with aldosterone. We've actually used spironolactone or derivatives of that for a number of people that have come in with blood pressure issues. I just had a guy from South Texas that came to me on 4 or 5 blood pressure medicines. We did some analysis for him. He had a concierge doctor. He had a cardiologist. He's on 4 to 5 blood pressure medicines. He couldn't really control his blood pressure. We did, really what I think is some pretty simple genetic testing, and figured out that he actually needed spironolactone. So we added that, took away a couple of other things. He was on a beta blocker. He likes to hunt in Africa and do all these things. He could hardly walk. We weaned him off his beta blocker. We did the cardiac action. Some of the beta blockers, particularly metoprolol, will raise central arterial blood pressure while at the same time they're lowering brachial, right? So he turned out that he was on carvedilol, which is a better beta blocker, but nonetheless, we were able to wean him off that. We left him on a low dose of an ARB and a little bit of spironolactone and, some supplements that we put him on. And the next thing you know, his blood pressure is completely normal. So you can really get people off their medicines. We've had good luck with this, right? Actually, when to add an aldosterone antagonist or not. So that's been very helpful. So these other genes are more about sodium, whether or not to use miloride, which helps you maintain potassium. It's like a thiazide, except you preserve potassium. Having a good potassium to sodium ratio is very important for lowering blood pressure. Mark Houston speaks about this a lot. So anyway, we like those genes. 9p21, this is a very important gene. It's kind of one of the earliest cardiovascular genes that was described, and you're probably familiar with it. It does associate with increased risk of both cardiovascular disease as well as MI, atherosclerotic cardiovascular disease, diabetes, and insulin resistance, and abdominal aortic aneurysm formation, thrombosis, plaque rupture, inflammation, and intracranial aneurysms also. And this gene is actually turned on by inflammation. So it actually causes inflammation and is fueled by inflammation. So when we see people with 9p21, one of the things that we do, and there are several things we do, but one of the things we do is we really look at their whole inflammatory oxidative stress pathways and really try to diminish that as much as possible, right? Another thing that works well here is optimizing vitamin K2, MK7 becomes very helpful here. And then the 6p21.4, coronary disease, MI, DVT, and the 4q25 increases atrial fibrillation risk and long QT. So more arrhythmias here. So when we see this gene in somebody that says, well, I'm a triathlete, it's like, okay, well, let's do some genetics for you. And they come back 4q25. We know that people that are endurance athletes, like really big time endurance athletes, Ironman, marathons, half marathons are probably okay. But anything beyond that, they're actually increasing their risk for atrial fibrillation long-term, as well as cardiomyopathy. So people run and they do these things to be healthy and demonstrate their health, but in actual fact, they're sacrificing their health, particularly if they don't know their genetics. So that's something to be aware of. And then there's dyslipidemia and metabolic markers. We look at these. The ones that are most interesting to me are the ones related to LDL or HDL dysfunction, right? So this ApoC3 is associated with HDL dysfunction, and SCARB1 is associated with dysfunctional HDL. So I'm not going to talk about this in great detail on the talk, but when it comes to cholesterol, we don't really pay a lot of attention, or we don't as meticulous in paying attention to cholesterol numbers as we used to be. We're big fans of looking at LP(a). We do like to look at particle numbers. We know that HDL can be misleading. You can have a high HDL and it's dysfunctional and it's not working properly. And so looking at these genes to see if somebody has ApoC3 or SCARB1 is very, very helpful to know whether or not the HDL is actually working. And then we're using another test where we can actually look at something called reverse cholesterol transport. So it turns out that reverse cholesterol transport is really the holy grail of lipid metabolism. What's your ability to get lipids out of the plaque or out of the cell membrane back to the heart? And so that becomes very, very important. So there are some tests out there. Cleveland Heart Lab has an algorithm that will estimate this for you. There's another lab that we use that's kind of more experimental. I'm not going to mention what it is because I don't want everybody to think that it's the holy grail just yet, but you can get an idea of this through a Cleveland Heart Lab. And I will say this, that when we do correlate direct testing of reverse cholesterol transport with the algorithm, we see that the algorithm tends to overestimate reverse cholesterol transport. So just be aware of that. It's probably worse than what you think. 9p21, we talked a little bit about this. It's also known as CDKN2A and 2B, right? There's basically two genes here that are being looked at. And again, it's associated with the things we talked about. If you're heterozygous for this gene across both of the alleles or both SNPs, you have about a 50% increase. If you're homozygous, you have about a 100% increase in having a cardiac event. There are many, many genes, however, that factor into this. 9p21 is associated with premature events, right? So younger people having heart attacks, many of them will have this. It's worsened by inflammation. So smoking really fans the flames of this. And when you see this gene, you want to do a lot to decrease inflammation. You want to think about vitamin K2, MK7. It's called the heart attack gene. We get aggressive about it. We let people know that they're carrying it. We let them know that we want to get rid of inflammation. So that means, getting rid of infections that are on board, looking at their detox genetics, being able to help them with that, improve their sleep, lower their stress levels is very important. We do a lot in the whole psycho-spiritual space to actually help people have a new perspective on life and lower their stress that way. Anti-inflammatory diet, right? Very important. So these are people that don't really do well with high-fat diets. They don't really do well with carnivore diets per se. A more plant-based diet is better for them. Things that are more anti-inflammatory, staying away. They do have a risk for diabetes, so limiting refined carbs and starches, and then exercise at least 4 times a week. Now, when they say exercise 4 times a week, here's the way to think about it. All right, so you're going to do cardio 4 times a week, but you're going to exercise every day, right? I do cardio 5 days a week, and I do resistance training twice, and I think that's a better way to do it. All of that leads to a better body composition, and then vitamin K2 as MK7. MK4 is good for bone health, so you need MK4 too, but MK7 is particularly good for keeping calcium out of arteries, etc. So, okay, so let's switch gears now and talk a little bit about the artery itself, now that we've talked a little bit about the genetics. And this is a diagram. This is a slide from Arterisol. You may be familiar with this company or this supplement. I was first introduced to it when it first came out, quite honestly, and was very enamored with the idea. You sort of think that an artery is like this, right? It has an endothelium, and then it has a media, which is muscular, and it has an adventitia, which is kind of fibrous tissue out here. In actual fact, we have 60,000 miles of blood vessels, controls many things, detox, oxygenation, hormone transport, nutrient exchange, etc. But in actual fact, the artery has this glycocalyx, right? That is this barrier that's negatively charged and sits between the blood and the arterial endothelium. So it looks more like this. So I showed you the picture before where it looked nice and smooth, but this is actually what it looks like. A healthy glycocalyx, this is proteoglycan and glycoprotein. It's almost like it's like the moss in the bottom of a stream, or it's like, the fuzz on your chin or whatever. But this can be rapidly destroyed and rapidly rebuilt. And it turns out it's negatively charged, and it's really what is the key protector of the artery. So I've changed my whole concept about arterial health into, if I was to distill it down to one thing, it would be maintain the glycocalyx integrity, right? That becomes the most important thing that you can do. So let's take a little look at that for a second. So the glycocalyx, you're familiar with the fact that when you start to exercise, your arteries dilate, you produce more nitric oxide. Well, why is that? Well, your heart's pumping more blood. The glycocalyx basically feels the more red cells going by. There's more shear stress, which then it sends a signal to the endothelium, hey, let's make more nitric oxide so we can dilate to accommodate this increased flow. It mitigates oxidative stress. It mitigates macromolecular leakage. When it's damaged, it leads to diabetic complications. It's also involved in ischemia and reperfusion injury. The fact that there is no glycocalyx, when things are reperfused, oxidative stress is enhanced. When you reperfuse damaged tissue, platelet adherence is mitigated. When the glycocalyx is intact, clots don't form, thrombin doesn't form, white blood cells don't adhere, which is important because lipids don't get into the wall of the artery when the glycocalyx is intact, right? So you can mitigate the risks of high blood pressure, coronary artery disease, erectile dysfunction. All of these things can be mitigated by taking care of the glycocalyx. It's that important. So let's just scroll through this. So the different pathologies that can show up, of course, cardiovascular disease, stroke, atherosclerosis, peripheral vascular disease, hypertension, diabetic and diabetic neuropathy, right? When this happens, erectile dysfunction, as we mentioned, and other vascular issues. So it's a big deal, and it's really kind of the main thing, and it's referred to as a smart barrier, right? And it is because it's selective, right? It's selectively permeable. It will actually keep cholesterol out. It keeps platelets where they're supposed to be and in a non-clotting state. It keeps out white cells. And it's other circulating components that stick and penetrate vessel walls are basically held back from doing so. It's micro thin, right? It's less than the thickness of one sheet of paper. I think 1,000 layers of glycocalyx is less than that. So it's very, very thin. It's an antioxidant. It harbors superoxide dismutase, right? So this is really the lead pin in the triad of superoxide dismutase, glutathione peroxidase, and catalase. This sort of cascade, this assembly line, if you will, of taking an oxidation element, free radical, and basically turning it back into water. So this is living in the glycocalyx, right? So if you have an ischemic injury and you destroy the glycocalyx from lack of blood flow, and then you put blood back into it like we did when we were putting stents in and opening arteries back up, we actually knew we were causing more downstream damage. It was better than the alternative of leaving the artery closed and accelerating mass necrosis in the myocardium, but you knew you were contributing to the damage. And it's because of this. We didn't know it at the time, but that's the reason why. Now we think about using hydrogen to basically upregulate superoxide dismutase and things like that if we're doing reperfusion. It's a regulator. It regulates vascular permeability, inflammation, coagulation, and fluid balance. And it's a transducer, right? As I mentioned, it basically can sense flow, increase flow, and the shear stress related to that to increase nitric oxide production. So this is a healthy glycocalyx. This is an unhealthy glycocalyx, right? This one's been destroyed. And this can happen in a matter of minutes. So what are the causes? Well, high blood sugar and insulin. So this is interesting. We think that if we eat a bad diet, that our arteries are being damaged over time. And in fact, there's an element of truth to that. But for the most part, if you spike your blood sugar, you are damaging your glycocalyx and you are damaging your artery right that second, right? So high blood glucose damages the glycocalyx. Insulin will also damage it, and insulin is a driver of senescent cell formation in the arterial wall. So when you have high insulin levels and high glucose levels, you're increasing the stiffness of the artery, right? More senescent cells, and you're destroying the glycocalyx. You're making it more prone to things like inflammation, oxidative stress, toxins, infections can attach, right? So if you have a healthy glycocalyx, guess what? COVID has a harder time attaching and causing the vasculitis that it caused and the clotting disorders that it caused, right? Pretty interesting. So stress, sleep deprivation, and sleep apnea all contribute as well. And then there's some genetic factors, and aging itself will do this, which is why I'm focused on being 27 for the next decade. So to optimize this, you can use a low sugar diet. You can use this arterosil product, which is a ramen sulfate from Monostronium natidium. This is an algae basically. And this ramen sulfate has been shown in multiple studies now to restore the glycocalyx. And we did one in my office that I'll show you in a minute, but it's also, there's data on it relative to protecting the arteries from COVID. There's another supplement out there called Endocalyx, which doesn't contain ramen sulfate, but does contain fucoidan. And fucoidan has also been shown to restore the glycocalyx. So just so you know, there's a couple of competing things out there. This is a study that was done looking at a normal glycocalyx that was 100%. Then it was exposed to high glucose, which knocked it down to 81% of what it was. But when they basically gave arterosil in different doses, you could see it was able to restore the glycocalyx. And so that's pretty interesting that it can regenerate. This was a study that we did in my office, actually. We took people and we did a max pulse for them. And then we gave them arterosil. And then we measured them again at 30 minutes, 60 minutes, 90 minutes, 2 hours, and 3 hours. And what you can see is that in most of the people, not everyone, there were a few exceptions, right? A few exceptions where people got worse, right? But in virtually everyone, the glycocalyx significantly improved the elasticity of the artery, the ability of the artery to dilate and expand, which is an indication that nitric oxide is working, which is a sort of an indicator that the glycocalyx is working to signal that, to enable that, right? So this was a study that we did. And when I saw this, I thought, okay, this is actually really working. This will be helpful. So the way that we prescribe it is we have people take it with meals, because it's during the time that you're eating that you're damaging the glycocalyx. It's when the sugar's going up that you're damaging it. So we take it with meals. If you take it in the morning and take it at bedtime, and that's maybe okay, but I want to be in there working when the damage is occurring. So pretty interesting study. There's also been associated with carotid plaque regression. So they took 2 capsules of arterosil a day, one twice a day for 60 days. And they did MRI scans. And what they showed was that there was a decrease in both men and women of decreased stenosis in the carotid arteries. You can use other things too, like aged garlic works. Nattokinase has been shown to decrease plaque formation in arteries as well. And you start to combine these things together, and all of a sudden you can actually, test somebody and see their plaque and then see it regress. It's like super satisfying. One of the things I love doing the most. So this is another topic that dovetails in here. And this was an article that was published in 2010. I came across it maybe 10 years ago. It doesn't seem to be well known, however, and it's aging-related NADH oxidase response to dietary supplementation, the French paradox revisited. So what the paper is basically telling us is that we all know that there's this French paradox, right? People smoking cigarettes, drinking wine, eating foie gras, high fatty foods, et cetera, maybe exercising, maybe not, and not really having the amount of heart disease that you would expect. And so the question becomes, well, why is that? So it's the Mediterranean diet. Okay, well, what is it about the Mediterranean diet? Is it the red wine? Well, it turns out that no, it's not really the red wine. You get a little bit of resveratrol out of red wine. There are much better forms of resveratrol out there now. I'll tell you, there's one called Vinia that's new to the market. That's a piceid resveratrol that actually has much better absorption than any other resveratrol out there, and activates a lot of genetics great for longevity, including Clotho, including FOXO3, including AMPK, including improving nitric oxide production and lowering ET1 to decrease arterial constriction. It's one of the things we used in that gentleman when we fixed his blood pressure and got him off the medications. So the point is, what is it about the French paradox? Well, resveratrol plays a role here, right? But it's not the main thing. What about olive oil? Olive oil is great. We love olive oil. Use it cold, activation of sirtuins, good longevity benefits. We love it. But turns out that's not the real ticket either, right? The real ticket in the Mediterranean diet turned out to be the ability of fresh grown herbs to actually interact with something called RNOx, right? So LAD oxidation correlates with levels of circulating age-related cell surface NADH oxidase. This oxidative stress contributes to arterial senescence and loss of compliance. Oh, there we are again, right? When the arteries have senescent cells, they lose their compliance, they get stiff. And it's this increasing RNOx, this oxidative stress, and this starts to go up for people at about age 40. So you may have heard about people that are in their 90s and they do studies on their arteries over there, like in Sardinia or places like that. We're in a blue zone, and they're basically living in these outdoor environments. They're vertically integrated across many generations, real good sense of purpose, physically active, and they're eating fresh herbs all the time in their meals. And these people have arteries like they're in their 20s, right? So it turns out, well, what are the herbs that have the biggest impact? Well, it's summer savory, it's basil, tarragon, rosemary, and then EGCG from tea, right? And so I don't know about you, but it's hard for me to find summer savory. I found it once, I think, at Whole Foods. Basil, that's easy. Tarragon, pretty easy. Rosemary, pretty easy, but this is a little hard to eat. What we did was we put all these into a tincture, this will be, I don't know if this is shameless or shameful, but one way or the other, we put this into a tincture, and I'll tell you about it. It's called the Gladden blood vessel formula, Gladden longevity blood vessel formula, because this is really powerful. I buy basil all the time and eat basil all the time. And if you want to improve erectile function, if you start using eating foods that are high in dietary nitrate, add to it basil, add to it Vascanox, and then Vinia, and use something to boost nitric oxide like Neo 40 or some other things I'll show you. I mean, it's amazing for blood pressure, amazing for sexual function and athletic performance. So very, very cool what you can do with this. So this is the blood vessel formula right here. And then this is, we have free radicals coming in everywhere. And there's another supplement I want to introduce you to, which is something called Fountain of Life that I recently came across. And I've been intrigued by it because one of the things that we see in our longevity clinic is that we have a way to look at transcriptomics and proteomics of the hallmarks of aging, right? We're doing 8 of them currently. There are actually 16 hallmarks now. 9 were published in 2013. You may be familiar with that. But the point is that what we see is that many people get lots of things under control. They get their DNA methylation age under control. They get their telomeres longer. They get their mitochondrial function working well. But one of the things that persists is inflammation and oxidative stress. And so we came across this supplement from a Norwegian spruce tree, lives a long time, can withstand tremendous oxidative stress. It's self-healing, has the highest concentration of lignans, right, of any plant out there. And it turns out these have very, very high anti-inflammatory properties. So I was interested in this. We tried it, and sure enough, I mean, it's pretty amazing. If you have people use just like 5 or 10 drops of this, immediately their energy levels go up dramatically. It's really pretty crazy. It does plateau over time. But using just a few drops of this gives you the amount of lignans that you'd have to eat, 1,800 cups of apples to try to replicate, or 50 cups of green tea, right? So it's a really nice way to get a natural, completely natural substance that has a really strong anti-inflammatory. And I don't have any financial ties to any of these people that I'm talking anything about, except the product that we developed. So nitric oxide optimization, well, a high nitrate diet, right? Things like NO beets is out there, beet elite as a substitute, but kale, arugula, spinach, beets, etc., bok choy, those are all high in dietary nitrate. Now, some people say, well, these have oxalates and I want to avoid those. That's fine. Pick the lower ones that are low in oxalates. But the point is you need some of these in your diet to have good dietary nitrate. And if you use something like Vasconox, it will actually supply this to you as well. Then there are these lozenges, NO2U, right? Nathan Bryan developed this. He also developed Neo 40 Pro back in the day. This, he believes, is even stronger than Neo 40 Pro. So we're transitioning over to this currently. Vasconox, right? It boosts usable dietary nitrate. And then Vinia, this Piceid resveratrol that raises nitric oxide and lowers endothelin-1. So these are things that we do to help optimize things in that regard. And then Cardia Action, I talked about this earlier. This is the blood pressure setup that can measure central aortic pressure, augmentation pressures, etc. So Cardia Action, if you want to track that down and look at it for your own practice, I have no financial ties to any of these people, but you might find that to be helpful. And this is basically looking at central aortic pressure versus an invasive catheter. And you can see that it actually tracks incredibly well with what you're measuring with an invasive catheter, right? So this is the invasive one. This is the measured one here. So it's really quite reliable in that sense. Also, it's interesting to know that central, systolic blood pressure central has a much higher correlation with events than systolic blood pressure in the brachial artery, right? So, look at this, all-cause mortality for hypertension versus optimal BP is 512% risk of stroke, right? 200% risk of CV death and 114% risk of all-cause mortality. So we think this central aortic pressure is actually a way for us to see more clearly where somebody is on the risk, and also to treat them and then see that it lowers. We feel it's more reliable and a better predictor than brachial blood pressure. It's one of the reasons we like it a lot. They're using this in New Zealand and they're using it in Australia, and they're having great success supplementing native people there with fish oil, omega-3s, and vitamin D. And they're seeing quite dramatic drops in central aortic blood pressure just with those two supplements, let alone all the things that we were just talking about. So I just want to mention that also. This is some in-clinic data showing people responding to interventions in Christchurch. The last thing I want to talk to you about is cardiopulmonary exercise test. And we use a company called MetTest. Again, I have no financial relationship to them, except we know them quite well. It's basically a metabolic cart. It's a bike test, right? Nobody falls off the back of a bike. If you're on a treadmill doing a maximal stress test, you can fall off the back. So it's quite safe. You wear a mask, just like this gentleman here is doing. We have you hooked up to a 12-lead EKG, and you pedal through a protocol where every 20 seconds, it can be adjusted depending on your athleticism, but somewhere between every 10 and 30 seconds, but typically every 20 seconds, it's going to get harder to pedal. And so with that, you have a graded exercise test. And what we're looking for is to look at your VO2 max and your peak VO2, right? So VO2 max is peak VO2. And this turns out to be an incredibly important predictor of longevity. The higher your VO2 max, which is really a surrogate marker for how much blood is your heart able to pump. The more blood your heart can pump per minute, the longer you live, the less heart disease, the less cancer, the less dementia. It's one of the strongest predictors of longevity, right? As well as health metrics. So we love VO2 max, and there are tables where you can actually give somebody a heart age based on their VO2. So we do this. You take the bike measured VO2 and you divide it by 0.85 to convert it over to what it would be on a treadmill. On a treadmill, you can generate a 15% higher VO2 max than you can on a bike. That's been documented over and over and over again. So there's a conversion factor. Then you go into the table for men or for women, and you can see how good is your VO2 max, right? So I'm going to complete 70 laps. My VO2 max now is exceptional, not just good or excellent. It's actually exceptional for somebody that's 40 years old. So that's, and I'd like to get it back into the 30s. There was a time when I was exceptional for somebody in our 20s. I'll tell you what happened. I got COVID. What we see with COVID is that everybody's VO2 max goes down, right? And their arteries get stiffer. Their VO2 max goes down. So how do you rebuild that? Well, I've been rebuilding mine, and I think it's just about back. I'm going to test again and see if I can go even better than I did before. But using different supplements, nattokinase, we've been using plasmapheresis, young plasma, some stem cells, things like that we have access to, EBU, ozone, the supplements I was talking to you about above. And I think with this, I've been able to rebuild my VO2. But I will tell you that COVID and also COVID vaccines decrease people's VO2. It also shortens their telomeres. We have great data on this. If you get COVID, your telomeres just got shorter. If you got a vaccine, your telomeres just got shorter. So really interesting information there. So anyway, you do this, and then there's an algorithm for how they recommend that you treat it. But the bottom line is you can get a great look at what's happening. So these panels also come out. And what you're seeing here is O2 pulses being measured, stroke volume. So this black line is the person pedaling a bike. It gets harder to pedal every 20 seconds up until they quit, right? They tap out. It's all they can do, right? They're fully anaerobic. And you get a measure of RER, so we know if they're fully anaerobic or not. Well, what happens as they're climbing that ramp, their stroke volume should go up in a linear fashion, just like this. And in this case, this person's climbing this ramp, but look what happened to their stroke volume. It didn't go up in a linear fashion. It tapered off. This is a sign, whoops, sorry, I'm clicking. This is a sign of microvascular disease. It's not specific to microvascular disease. It could be related to almost anything that's bothering the heart. It could be diastolic dysfunction. It could be valvular dysfunction. It could be pericardial constriction. Could be microvascular disease, macrovascular disease. But in the vast majority of people, we'll see that this is the case. And what we do is we work with all these different arterial interventions that I've been mentioning along the way to get them to come back into a linear shape where their arterial function is perfect. And when they do that, their VO2 max continues to climb and go up. So I can show you this. If somebody's sick and they're climbing this ramp, their stroke volume will come up, but then will crater before they finish. When that happens, the heart rate will increase to try to compensate for that lower stroke volume, right? So this will increase, and it's measured as a heart rate, work rate, slope. What's the slope of the line before the anaerobic threshold compared to what it is prior to finishing? And if the slope is steeper, then it's positive. So plus 15 or less means that they're in good shape. So this guy, stroke volume's tapering off, heart rate has to increase. He's plus 80, which is greater than plus 15. So you know that he's got at least microvascular disease. The people you really worry about, though, are when this compensatory mechanism of an increased heart rate to compensate for the decreased stroke volume isn't working. Because look, his VO2 continued to rise the whole way, right? But if VO2 tapers off, that's a big problem. We send those people for cath, clearly CTAs, and even some of these people will get a clearly CTA depending on what this looks like. But this becomes an exquisite way to look at vascular function in the heart at maximal stress and see where somebody is and who needs further evaluation, who can be treated safely with supplements, medications, dietary interventions, things like that. So I wanted to share some of that with you. This is the book that I mentioned earlier, 100 is the New 30, How Playing the Symphony of Longevity Will Enable Us to Live Young for a Lifetime. It's available on Audible. I actually read the book myself. It's about 450 pages, so it took me a week to read it. But it's a great book, actually. I go through an entire construct of how to think about longevity, life energy, longevity, the drivers of aging, health, and human performance. And I think you may enjoy that. So anyway, with that, I will stop. I'm not sure how much time that took, but here we are. Okay.
All right, and we're back. So I took notes of how many questions we got. So I'm going to scroll back up to the very top and make sure we go from the beginning. Here's our first question, came from Kenton.
Okay. I love Kenton. I just want to say I love Kenton. So.
Does the FFR-CT with AI do the best job of identifying plaque risk versus CCTA?
Yes, it does a better job. If you're looking at FFR, right, FFR is basically fractional flow reserve, which is another way to get at, is the obstruction critical or not? Does it really obstructing flow? That's another technology that can be used. So FFR, intravascular ultrasound, they can both give you useful information. And so it is better. Yeah, FFR and this basically this metric to try to gauge what's happening better with the clearly CTA is a better CTA than just a regular CTA.
All right. Mm-hmm. Moving on to our next question from, I hope I'm saying this right, Arcana Staw. Recommendations for ambulatory blood pressure monitoring, how, where to order as a general physician, not a cardio.
Yeah, so I think there is a role for this. I know Mark Houston's a big fan of it, 24-hour blood pressure monitoring. I have to say that it's a little bit cumbersome, and we haven't really gone down that path. We tend to rely on the pieces that we have that we see with stress testing. Of course, we're measuring blood pressure during the stress testing, right? So we get a good idea of how people are going to respond. And then we do the cardiac action, we do the max pulse, regular blood pressures. And with that, I don't know that we're missing a lot. We also do sleep studies, so we see whether or not people have elements of sleep apnea and things like that, right? So, but I think it's a good tool. If it's a tool that you like, I would encourage you to use it. I think you do get useful information that way. So it's just not one of the first things that we jump to. So,
all right, thanks for that answer. Next question here. I heard of patches for ambulatory blood pressure monitoring. Do you recommend these?
I don't have any experience with them, so I really can't speak to it. I don't know. I think that sensors in general are getting better. What we're able to detect and the accuracy of them seems to be getting better. But I don't have any real experience with them. But actually, I'm interested to explore that because it may be an easier way rather than having somebody have a cuff blow up on their arm every, however many minutes while they're trying to sleep, right? That just always seems so cumbersome to me. I'm not sure what you were actually getting. But if it could be done through a patch, that would be interesting. Yeah.
All right. Next question is about that Cleveland heart test for reverse lipid transport.
Yeah. It's basically a Cleveland Heart Lab panel. You can get it through Quest Diagnostics. If you order Cleveland Heart Lab panel, you can go in and customize the panel to yourself. And if you look at the algorithm for reverse cholesterol transport that's on it, that's how you get that information. So.
All right, thanks for answering that one. And then optimal dose of the quinone 7.
Yeah, that's a good question. I forget the exact dose, so I'm not going to misquote you something. But we tend to use sort of the higher recommended dose. I will tell you this, I'm not in the clinic every day anymore. I'm out doing a lot of other stuff, working on other therapies and things like that. So the clinical team handles most of that. So I don't want to misquote you there. How high on vitamin D? Well, vitamin D is interesting. We have a lot of people on 5,000 and 10,000 international units. And sometimes it's good enough and sometimes it isn't. We're also looking at vitamin D2 and D3, which we also pick up on the Cleveland Heart Lab, and we'll put people on 50,000 units of D2 once a week. Then there's the vitamin D receptors, right? The VDR receptors. And so being able to activate those with things like sulforaphane becomes really, really important. So there's lots of different pieces to vitamin D. So it's really individual. If you don't know somebody's genetics and you're not measuring D2, D3, looking at it through different lenses, I think, you gotta do that to get the right dose for the individual. So.
Perfect. All right, we've got some compliments from your presentation here, and then a request to explain the use of nattokinase and a source.
Yeah, I may have a source. Let me just looking at something. So the dose of nattokinase, they're using up to, I think, 10. Is it 10? Let me look at this real quick. Again, I'm not great on the dosing because I'm not in the clinic, so forgive me for that. But I know that I actually just grabbed something here a minute ago, not a minute ago, but a little bit ago, that may be helpful to answer that. And I'm not seeing it right this second. So anyway, I can, I'll get you something you can send out to the group here. So there are many sources of nattokinase. There is another kind of nattokinase that apparently is even better than, and it's called lumbrokinase. We've heard that lumbrokinase actually is more beneficial than just regular nattokinase. Nattokinase, of course, comes from fermented soybeans, from natto. And I think, there's a lot of data with nattokinase. I need to look at lumbrokinase a little more closely. But on plaque regression, on actually improving cardiovascular function related to COVID, helping to get rid of spike protein with things like bromelain, some other things. So I think there's a real place there. Yeah.
Right. Another question about nattokinase. Can you take with Eliquis?
No, you got to be super careful, right? If you've got a bleeding issue or you're on a blood thinner or even aspirin, you've got to be careful. Like if I take too much fish oil, I can get nosebleeds. So you have to kind of know who you are and where you are. And certainly if somebody's on Eliquis, they probably don't need nattokinase for blood thinning, right? So you got to be careful there. And if they're on Eliquis, they're probably on it for a reason. And it's a little tricky to just stop that, and say, well, I hope your AFib's okay or your DVT doesn't come back. So, you got to dance around that a little bit. Yeah.
I think Rita may have missed this earlier. Which company's resveratrol is good?
Vinia, Vinia, Vinia. Yeah, that's the company. They do it. And they make this. They grow these grapes in bioreactors, and they stress them tremendously inside these bioreactors. And that's what resveratrol is, right? It responds to just like we do well with hormetic stress, right? Like exercise and saunas and all these things, right? Well, plants do better with hormetic stress too, in terms of creating these polyphenols that actually help give them robustness and strength and the ability to recover, right? So when you stress the plants. That's why you don't want to water your plants too much. Stress those guys a little bit, right? And then water them back. They actually come back in a more robust way. So they're getting very, very high levels of Pisceid resveratrol out of these bioreactors. And I know they're working on. Again, I have no financial investment in them. We are getting ready to do a Vinia trial in the office where I showed you the arterial still trial. We're going to actually do that with Vinia and see what impact that might have on arterial elasticity. We're also going to measure Clotho levels. So Intellex DNA will now give you your genes for Clotho. And I don't know if you're familiar with Clotho, but it's very, very important for cardiovascular health. Higher Clotho levels are associated with greater cardiovascular health, kidney health, brain health, and it's anti-aging and from the standpoint of longevity, right? So you want to have good Clotho levels. The best genes to have for Clotho are to be heterozygous. Those people make the most Clotho, right? So if you're homozygous on the low end, you're really kind of in a bad spot. If you're homozygous on the high end, you're in a better spot, but not the best spot. You want to be heterozygous. So I'm homozygous on the good end. I have a client that's homozygous on the bad end. I was just looking at this. We have him taking Vinia. We have him taking Abmacol Extra, which is a form of sulforaphane. And both of those will raise Clotho. In addition, cardiovascular exercise raises Clotho, right? So doing cardio raises Clotho, whereas lifting weights lowers Clotho. So this guy's doing cardio 5 days a week. He's taking Vinia. He's taking Abmacol. We measured his Clotho levels. His Clotho levels are rock solid normal. And yet, genetically, he's really predisposed to have low Clotho levels. So that's pretty interesting to us. It's an N of 1. We want to look at it more and see, can we take people that are genetically challenged, get them to do the right exercise, put them on the right supplements, and actually get their Clotho levels back to a good range. So, yeah.
Okay. Another question from Kenton about which range to shoot for vitamin D status.
Yeah. I know there's a lot of controversy about this. We like it over 70 to 80. Mine tend to run about 100 to 110. But, my intracellular vitamin D levels are about where they're supposed to be. I don't have any sequelae or side effects from it, right? So I think sometimes we get obsessed about some things, and I think there's a little more wiggle room in biology than what we think. So if somebody was at 69, I would not be in a panic. If they were at 92, I would not be in a panic, right? So if they're at 400, I would think you have a problem. But if they're bouncing around that area, I think you're okay. So
great. Okay, another question from Nick. Thoughts on clearly with CCTA?
CCTA. What are we talking about? CCTA? Carotid? No. Coronary? CTA? I'm not sure. I don't understand the question. Clearly is used primarily, as I understand it, really for coronary arteries. So it is in and of itself, it's a technology. You can actually go get a coronary angiogram with a CT scan and then put the Clearly software on top of it, right? So you can submit your CT angiogram and then have it analyzed, or you can just do it all at once. So that's how I think about it. Yeah.
Okay. And then Susan.
Let me just say this though. One of the things that's really, really important to remember is that when you're evaluating somebody's cardiovascular system, it's important to understand the anatomy, right? But it's also important to understand the physiology. And if you don't have those two pieces, you're really missing the boat. So you want to have the anatomic piece, but you've got to get the physiologic piece. And I would be curious to know how many people in the audience are actually doing cardiopulmonary exercise tests, right? Or doing max pulse, or doing a cardiac action, or things like that, where we're starting to look at the physiology in very sophisticated ways. Because I think, we can get caught up in the CC, the CT angiograms and the Clearlys, but you have to understand that even when you do that, you do not have any physiologic data. You have an estimate of an anatomic structure. That's all you have. And I learned early on in cardiology that you have to have physiology and anatomy to actually understand where somebody is. So just make sure that as you think about this, you put those two pieces together.
Great points. Question from Susan about comments on use of Vascepa versus fish oil versus SPMs.
Okay, I'm not familiar with Vascepa. I am very familiar with fish oil and SPMs. So they're different, right? Fish oil is omega-3s. You're looking to get omega-3s into cell membranes. You're trying to do things with that. SPMs, we use SPMs. They're a derivative of fish oil, special pro-resolving mediators. We use those to help resolve inflammation. Could be neural inflammation, could be inflammation in your ankle, right? But we think SPMs in conjunction with hydrogen do a good job of helping with pain. And then if we're treating the brain, I found that all brain fog is basically neuroinflammation. We find that SPMs do a little bit, but Miraca really works well. So that's a combination of a couple different things, luteolin and PEA. And that combination seems to work amazingly well for brain fog. So I think if you start to think about brain fog really as neuroinflammation, and it can also be some other things, right? It can be, blood sugar's low, or hormones are off, or thyroid is down, or things like that. But for the most part, if those are optimized and somebody's getting foggy, think about neuroinflammation, and think about food driving the neuroinflammation, and then think about the gut leaking and driving the neuroinflammation, right? So you've got that whole sequence to go through. But I've found that something like Miraca works really, really well to decrease neuroinflammation. So
great. Thanks for that suggestion.
Mm-hmm.
Another suggestion on the best sulforaphane supplement.
Yeah, Avmacol, AVAMOCL, Avmacol. It's basically sulforaphane with myronase. So it comes with the enzyme that actually activates the sulforaphane. So in that case, it's actually, we think it's better. We use it. When you do genetic analysis on people and you see all of the different genes that are modulated by sulforaphane, either to upregulate or downregulate or bring them into a more optimal pattern, I mean, it's kind of like God's gift to your genetics, quite honestly. So I think we have virtually everybody taking it, right? Unless you've got an allergy to sulforaphane, you should be on it, quite honestly, the way we think about it.
That's the one that upregulates NRF2, right?
It does upregulate NRF2, right? And we have a shroom formula we created also that downregulates NF-kappa beta. For on the inflammatory side, I didn't mention that. It's a combination of about 5 different mushrooms, reishi and turkey tail and some other ones in there. So yeah, good stuff.
Love that you've developed all the best things to use. Like have a whole I
don't know. There's more to go, right? There's more to go.
Question about taking Miraca long term.
Yeah, I use it intermittently, right? I do take it most days, but maybe like 5 days a week. I think supplements in general, I don't, this idea of trying to do something every single day, right? I mean, there's a few things like that, like thyroid, right? Or something like that. But trying to take something every single day, I'm a bigger fan of kind of cycling in and out. And I think one of the real keys to the symphony of longevity is actually modulating between mTOR activation and AMPK activation. We know that mTOR is important. You've got to have bone density, muscle mass. You need testosterone, you need estrogen, you need growth hormone. And so when I'm going to push in that direction, I push in that direction. But when I'm pushing in the other direction, I'm not pushing in that direction. Now I'm using spermidine and saunas and more cardio and things like that to really activate autophagy and AMPK and, resveratrol to Avinia to basically, drive FOXO3 and all the things you want to do on the restorative side. So then you cycle in and out, you back and forth, right? You're back and forth. It's the best way to play the game, I think, currently.
On that note, any thoughts on metformin and rapamycin for
Yeah,
longevity?
metformin, it's interesting. There's all this buzz about metformin. Now it turns out that maybe it's really only useful in diabetics for longevity. May not have a general applicability. We use dihydroberberine or berberine in place of it, quite honestly. There are other ways to activate AMPK. Resveratrol will activate it as well. Rapamycin we're fans of. So we cycle in and out of this too, right? So there are different, depending on who the person is, where they are in the aging process, and what their underlying risk is for certain things like cancer, et cetera, we may have them take it everything from once a week to every other week to every third week to maybe once a month. It just depends on who they are and where they are. The thing to understand about rapamycin is that the half-life is 60 hours. It's a 60-hour half-life. So 4 half-lives to get it out of your system, right? So that's 10 days. So if you're taking it every week, you never really get it out of your system, right? And so I think there's some wisdom in, we have some people with cancer and some things like that where they're taking it every week. That probably makes sense. But for most people, I think taking it every other week or every third week, where you're on it and then it's out of your system and you're back on it, right? You want mTOR, then you want to block mTOR. I think there may be more wisdom in that. So just something to think about. But we're fans of it. Yeah, we use about 10 milligrams typically. We can go up or down depending on the size of the individual, a couple other things. So
Great. That's all the questions we've had. The final questions have to do with reaching out to you and getting your services or your office. So do you do remote consults?
We do. We have a telemedicine program. Most of our clients, medical legally in Texas, we need to see a client. At least once a year. I will say this, I am getting ready to, and if you're interested in this, you can let us know about it. There is a slide I should have shown you that I didn't show you. I don't know if I can share my screen again.
Sure.
But let me see if I can do that. But I'm going to be putting on let me do this entire screen, allow. Let's see if you can see this. So I'm going to be putting on a course. I've had many people ask me, can you teach me what you do in the longevity space? If you check out the book, you'll see all the different things that we do. And so I am going to put on a longevity certification course, actually. And if you're interested, you could scan this and let us know. We're thinking about launching, and I have several promos for it coming up in April. With some people that want me to present this to their group of physicians and things like that. And then we'll probably kick it off in May or early June. So if you have an interest in this, let me know. And that would be helpful for us to kind of gauge your interest. But it'll be a longevity certification. It'll be based on the book, but we'll go deeper. And at that point, we will talk about dosage and some other things. We'll get more specific about some things than we did here today. So, yeah.
Okay. Thanks for sharing that. And then the final question was, people want to know how to contact you. How can we get in touch with you?
Yeah, so you can go to gladdenlongevity.com. That's the website. You can always get to us that way. If you want to shoot me an email, my email is gladdenj@gladdenlongevity.com. So just my last name, first initial, @gladdenlongevity.com. And if you're nice to me, I'll share my cell phone with you. So
Love it. Well, we have answered all of the questions that came in. Thank you, everyone, for submitting your questions in the comments. Dr. Gladden, that was an amazing presentation. Thank you so much for sharing your wealth of knowledge with us today.
My pleasure. Yeah. Great. Guys, I really hope that was helpful. It's my goal is to be helpful to you. So hopefully I've changed your thinking a little bit. And really appreciate the questions. And Kenton, like I said, I love you, man. So good. All right.
Take care, everyone. Have a great rest of your Tuesday.
All right.
Stay vibrant.